I'm Dr. Winston Carhee. I'm a board member of the Clinical Compass. I am also the American Black Chiropractic Association representative on the Clinical Compass board. Today, I'd like to share with you one of their recent practice guidelines that they have developed about chronic pain. So I'm going to review this particular piece of literature. Let me share my screen, please. Okay, here I'm showing you a publication of the Journal of Alternative and Complementary Medicine, a very renowned journal, peer-reviewed journal, and the Clinical Compass had this paper published. I believe it's in 2020. It's called The Best Practices for Chiropractic Management of Patients with Chronic Musculoskeletal Pain, a clinical practice guideline. And we talked about clinical practice guidelines in a previous video, and this will cover an example of these guidelines. And this was done because we have some very talented individuals who are part of the Clinical Compass on this particular paper. Cheryl Hawk, DC, Wayne Wallen, DC, Ronald Farbaugh, was a good guy, Clinton Daniels, Amy Milkis, David Taylor, DC, Derek Anderson, PhD, Chris Anderson, DC, Louis Crivelli, DC, who's our current board chairman, and also Morgan Clark, DC, Elizabeth Barlow, and David Paris, DC, along with Richard Sardinart, MD, and John Weeks, who I believe may be a member of the public. Well, this is the paper that we will be reviewing. Okay, so the purpose. The purpose is to develop a clinical practice guideline for chiropractic management of chronic musculoskeletal pain. Right? We have a lot of patients who present in our offices with this type of presentation, but currently there's not a single clinical practice guideline addressing non-pharmacological approaches to more than one type of musculoskeletal pain as a primary complaint. And we know this happens a lot, right? So the chiropractic profession primary approach to patient care has traditionally been spinal manipulation, but its scope of practice includes many other non-pharmacological approaches. So what about our entire treatment of these patients with chronic musculoskeletal pain? How does that look in the literature? Well, this is unique about this paper is it's a randomized controlled trial of non-pharmacological treatments, particularly manual therapies, usually assumed to be a curative model, right? As an example, this randomized controlled trial usually tests the hypothesis that a course of spinal manipulative therapy will result in long-term pain reduction, which is a curative model. If it does not, then the spinal manipulative therapy is considered ineffective, and by default, the whole treatment. But this paper, was developed by the Clinical Compass to be a collaborative, multidisciplinary project that emphasizes the current treatment model that the chiropractors use. So we're taking into account the International Classification of Disease, the 11th edition, right? There's a new category of chronic pain that includes the following disorders. Number one, chronic primary pain, which includes disorders such as fibromyalgia or back pain, which is not otherwise classified. So how do you treat these individuals? What about chronic cancer pain? Or maybe chronic post-traumatic or post-surgical pain, right? And then you have chronic neuropathic pain. A lot of these patients present. And then you have chronic headache or orofacial pain, which includes temporomandibular joint pain, or chronic visceral pain. And what about chronic musculoskeletal pain, which will be addressed in this paper. Now, the AHRQ and the Institute of Medicine and the National Pain Strategy Report say that recommended that chronic pain be addressed through a biopsychosocial model rather than solely through the conventional biomedical model. This includes an emphasis on non-pharmacological and self-management approaches, with pharmacological approaches being secondary, right? Let's repeat that. They emphasize non-pharmacological and self-management approach over and above the pharmacological approach, making sure you do that after what? Chiropractic first, right? Drugs and surgery last, okay? So what are we talking about? What type of conditions? We're talking about the lower back pain, talking about neck pain. We're talking about chronic tension headaches, or knee and hip osteoarthritis, or fibromyalgia, which is pain over a general area. All of these are the top 5 chronic pain conditions that will most likely present in your office seeking your care. So, the Agency of Healthcare Research and Quality included the 5 conditions covered in the AHRQ review, updated 2020, which are amongst the most common causes of chronic musculoskeletal pain. So what are the recommendations? They want to emphasize the biopsychosocial model, and they prioritize self-management and non-pharmacological approaches. They emphasize active interventions, which include both physical and the mind and body approach. They identify neurophysiological type of pain that you're treating, and then you must consider the risk stratification. So different individuals have different susceptibility to risk. You should emphasize the biopsychosocial model. This is different, right? Management of patients with moderate to severe and or complicated chronic musculoskeletal pain is best addressed when you have a biopsychosocial model rather than the conventional biomedical model. This is big. This is a unique change to think about, right? I believe individuals are energy, spirit, right? Mind and body. This is getting more into that realm, and they codified it here. So, supported by the AHRQ and the International Society of Study of Pain, then they're saying this is a valid way, most effective way to treat the people presenting into your practice. They prioritize self-management and non-pharmacological approaches. Let's talk about this again. They prioritize self-management and non-pharmacological approaches, right? Because of the overuse of opioids in this chronic pain population. For patients on prescribed pain medications, they're suggesting that they be co-managed with providers of non-pharmacological approaches. This is big. So you can go to every single interventional pain management practice and tell them that they should be working with you. Here's the proof, right? Coming right from the authorities. For patients on prescribed pain medications, they should be co-managed with the provider of non-pharmacological approach, chiropractic, if they want to improve their outcomes. All right, emphasize active interventions. You have passive therapies and you have active therapies, right? So you have passive interventions and you have active interventions. So passive interventions are useful in the initial stage of management to do what? Decrease pain. This is in every textbook. If you look at it physiologically, you know what your treatment does and how it helps, but now you can explain it, right, with passive interventions. But the active interventions are what we do, particularly exercise and self-care, should be introduced as soon as possible. Exercise, self-care should be introduced as soon as possible in your care plan and emphasized in the management plan, because we know once you get them out of the bodily injury, they have to go to functional maintenance in order to manage the pain. And they still should be doing exercise and self-care. Follow this. Medical necessity, people. Okay. Include both physical and the mind-body approach. So for patients reporting moderate to severe chronic pain, a non-pharmacological approach that includes both a physical and mind-body component. This recommended. This is a paradigm shift. This is, I believe, record-breaking. We have this approach. It's chiropractic, if you ask me. This is my interpretation, right? A non-pharmacological approach that includes the physical, adjusting the spine, and a mind-body connection. What is that? That could be the body communicate to the brain, and the brain communicates to the body. Okay, and guess what? You want to get into the psychosocial model and find out what's going on in the patient's lifestyle that may be contributing to the feeling of this chronic pain. Okay, that is recommended. These may be administered by a primary treating clinician or by a referral or co-managed with an interdisciplinary team. Again, the team approach is better as long as we're all focused on the proper patient outcome, utilizing different types of practitioners who use different types of modalities to have the same effect. This is the new and accepted model. You identify neurophysiological type of pain. You differentiate the patient's chronic pain in terms of neurophysiology. Is it neuropathic, nerve damage? Is it nociceptive, pain sensation? Or is it more in the central sensitization? So some problem with the spinal cord or a disc bulge or something that may be causing centrally, right? Neuropathic, right? The nerve pathway, peripheral nerve, nociceptive, pain, irritating fibers, some tissue damage, or is it the central part of the cord that has some damage? This may affect treatment choices, and it should. And you should do this differentiation process. Neuropathic, nociceptive, or central sensitization. What is causing the pain here? Right? Consider risk stratification. They have this outcome assessment tool, which it is called StartBack, risk assessment tool. And new episodes of pain inform shared decisions about treatment approaches. The patients at low risk or poor outcomes may require a less intensive approach as opposed to those with the higher risk. They have more intense outcomes and different type of interventions. And they should include a psychological component to make sure that the subluxation is not above C1. Sometimes it is. You should engage the patient in informed consent process, which requires an active communication between the patient and the clinician. So in your consultation, you should talk about this. You should not miss this. You should go over, right, the consent. You should use clear and understandable terms. The clinician explains the examination process. We do it step by step. You go over the diagnosis. This is what I'm diagnosing you with, and here's your treatment options, including no treatment. But you don't have to undergo chiropractic care. You could try to handle this on your own. But you go over what might be the risk. If they do decide to do this on their own, it could get worse, right? What's the benefit if you do decide to have me treat you? Here are the upside, right? Or what are some other options, right? They might go get to a needle, right? Or surgery. It's up to you. You should present that to the patient. The clinician should ask the patient if he or she has any questions and answer them to the patient's satisfaction. The patient must understand this information to make an informed decision. The information, consent, discussion, and the patient's consent process should be recorded, documented in the medical record. Get a signature, sign up on it. Boom, you're good to go. Right? So documentation of consent, this is in California. It says licensed doctor chiropractor shall verbally and in writing inform each patient of the material risk of the proposed care. We are not in California, obviously. We're here in Georgia, and we have our own regulation and guides, but let's look at it. This is what it says should happen for informed consent. All right. Provide sufficient information to the patient to allow the patient to make an informed decision regarding treatment, which includes purpose and nature of evaluation and our treatment regimen, alternatives to treatment, any side effects and benefits of treatment regimen, proposed alternative to that treatment, and estimated cost of treatment and alternative treatments. And the right the patient has to withdraw from treatment or decline a particular type of treatment that will be recorded, documented, and photographed and preserved, otherwise used in an educational program. Sign it, scan it, you're good. If they want to terminate any treatment contract at any time for any reason with no fee or penalty, okay? So if they prepay, cool. Simply divide out their payments with what they got, and then boom, there you go. But it has to be written in the contract, and you have to, they can terminate at any time, no problem. Cover your assets, okay? So maximize patient safety. Non-pharmacological therapies have fewer associated harms than pharmacological interventions, or more invasive interventions for that matter. Carefully assess the patient for possible contraindications to manipulation, and particularly to high velocity, low amplitude thrusts, maneuvers, and if they have any red flags. You got to do your due diligence, of course. So what are red flags? They're not necessarily contraindications to your managing the patient, but it is a finding that requires further diagnostic investigation. Further diagnostic investigation. What might that be? An X-ray, of course, which we should do, and we have been trained to do. But what about outside referrals to maybe an MRI? Think that might be helpful? I think so, especially if it's called to come into question. Or referral before possible conservative care begins, before you even see it. Okay, so what are some historical red flags that present to our office, right? Known connective tissue disease, osteopenia, significant trauma, right? Unexpected neck pain, especially ages 20 or 55 or greater, less than 20 or 55 or greater. You have cancer, unexplained weight loss, severe nocturnal pain, pain at night, look out for that. Confusion, altered consciousness, right? Visual, speech disturbances, and weakness or a loss of sensation. Avoid routine use of imaging, right? Don't want to overuse the imaging. So you have chronic muscular pain is often multifactorial. I'm talking about chronic pain here, not the acute pain. Right? But the chronic pain can be multifactorial and may not originate from a local source. But again, they may have these positive feedback loops that's been set up, again, psychosocial, all these other different causes that could be contributing to, and not just tissue damage. Remember what's down at the bottom, okay? Imaging evidence is rarely capable to definitively identify the pain source when you deal with chronic musculoskeletal pain. Imaging may be necessary if red flags are present and should be evaluated on a case-by-case basis after a thorough history and a thorough examination are performed. Use validated patient report outcome measures. These are big in my practice. Hopefully you have about 4 or 5 of these on every patient, right? But assess patient symptoms and characteristics and assess the progress over time. In the beginning, the middle, and the end, uses outcome assessment tools to help evaluate the progress. They have table 11. We talk about the current practice guidelines as a list of outcome assessments used for pain characteristics, functional ability, quality of life, and psychological factors. Again, pain characteristics, function, quality of life, and psychological factors should be evaluated on the majority of the patients, but especially on these, right, chronic musculoskeletal pain patients. Here they are. We have pain characteristics here, right? Verbal pain rating scale, numerical pain rating scale. You have the functional ability here, patient-specific functional scale, pain disability index, I use that a lot, right? And brief pain inventory. Then you got the quality of life, right? You're talking about medical outcome studies, right? SF-36, and you got the global well-being scale. And then you got the physiological factors, right? These are ones we use a lot, right? The PHQ-9, which I use. And then you have the physical moods, also coping skills. And this one, which I find very interesting, the PTSD checklist, right? That's one you want to have in your arsenal as well. You want to make sure you're following the appropriate care pathways, right? And they have these algorithms out there, and they're very, very useful. If, then, this, that. You can follow along and decide exactly what to do at appropriate time. Examples of chiropractic care pathways for a typical adult patient with chronic musculoskeletal pain and considerations of frequency and duration of treatment all can be evaluated if you follow the appropriate pathway. Then again, following the GPS, turn here, go here. If this, then that. How much and how long should you treat an individual, right? You have the type of episodes, right? And then you take, depends upon the number of treatments you have, and then how long or treat that particular episode. Then you have the reevaluation period that you're going to do in some timely fashion, okay? So either it's mild, moderate, or severe. And you have different types of treatments, number of visits based upon the presentation of the patient with the chronic pain. And that it takes the duration and then the time that you want to reevaluate the person, which should always be within, right, what, 1 month, right? If it's more severe, or maybe quicker, or less quicker, if more severe, maybe longer. So you follow this protocol and you cannot go wrong when they're trying to question your clinical reasoning. Set appropriate chronic pain management goals. The goals of chronic pain management are different from the goals of acute care management. Let that sink in one more time. Your goals of a chronic pain management should be different from your goals of acute pain management for obvious reasons. You want to maximize the patient's engagement in meaningful measures of activities to de-emphasize pain. Examples, their ability, right? Their function should be emphasized when considering chronic pain, right? Playing with grandchildren, getting your hair done, or going to the park for recreation, right? Set appropriate chronic pain management goals. So chronic pain goals may include, but not limited to, pain control, relief, or tolerance, support or maximize patients' current level of function or activities of daily living, reduce or minimize the reliance on medication. That's a biggie. And then maximize patient satisfaction to feel better, but maximize the patient's engagement in meaningful, pleasurable activities. All right? Reduce duress, loss of enjoyment. All right? Minimize exacerbation frequency and severity, and you want to minimize their disability or ability not to do certain things or function certain kind of ways, and minimize lost time at work on the job. What's next for Clinical Compass? Well, several things. We have chiropractic in COVID-19 pandemic era prevention and treatment, which has been published by the time of this paper, this presentation. An Asia Pacific Chiropractic Journal they're trying to produce and come out with. We have a new update on prevention and treatment. And clinical practice guidelines on the role of chiropractic in disease prevention and health promotion. That is currently in the process. Then we have an update on the lower back pain clinical practice guideline. And this is important because the guidelines are only valid for about 5 years in the research, right, environment, and they then need to be updated. And we are currently in the process of updating the clinical practice guidelines for lower back pain. This is important because every single one of these chiropractors in here are treating lower back pain, and the third-party administrators need current literature to support what we are doing in the reimbursement of these treatments. Enough said. And best practices and white papers as dictated by the movement of the profession. And so in the ABCA, we're working on our best practices concerning the doctor chiropractic programs and racial diversity, as an example. This can all be accessed through our website and the Evidence Center, which would give you different topics and distill down the appropriate research as it relates to the chiropractic profession that you can use to guide you to understand how to treat the patients when they present with these type of presentations, such as chronic musculoskeletal pain, where you know this will give you your medical necessity and help you communicate to third-party administrators, which we love dearly. This will help you in practice today. So the Evidence Center, it will distill down all of the topics in the presentation of your patients as it relates to chiropractic and give you a guideline GPS map to how to treat the patient and communicate the medical necessity of your care to the third-party administrator. You don't have to go to PubMed and type in neck pain and get all this data and figure out how you decipher it down to you and your practice. This has been designed specifically with you in mind. So what does the Evidence Center actually produce? We are experts who have curated studies with a summary of the findings as to why, right? You get clarification of what exactly is you're doing. It's a time saver. You get about 2 updates a year. This is a way you can impact, right? We make an impact because people contact us. They have problems with reimbursement, and we give them the evidence and the literature, and they take that back, and then they get decisions policies overturned and changed. This is big. You can get policies overturned and changed when you're dealing with the big blue or Aetna or ASH. The evidence is your friend. Currently, 5 years is considered old in the research community. So therefore, we're updating our guidelines on lower back pain as an example. Organize the topics. 2 new topics added last year, opioids and COVID, and we're having more forthcoming. So anytime we're able to nimbly respond to the profession as the profession needs it. We have future and upcoming features and documentation, so please stay tuned to the Clinical Compass in order to be in the know. So here's our evidence center. Here's how it looks. If you have back pain, click that button and get all the related research for chiropractic and treatment in your profession. Simply by clicking that button, and you'll get the specific research topics and guidelines to help you. Also on COVID-19, neck pain, and many, many other topics and patient presentations. All here in the Evidence Center. So let's talk about current updates. And this will conclude the video for the review of the paper on chronic musculoskeletal pain. We hope you have enjoyed this and you will tune in to other videos. I'm Dr. Winston Carhee with the Clinical Compass and the American Black Chiropractic Association. Thank you. Have a wonderful day.